Everybody to this latest in our series of Candela webinars. This afternoon we're going to be discussing vascular treatments. So Jens is going to start by covering the treatments you can do with the Nordlys system, and I'll follow that up with a discussion around hemangiomas and port wine stains, primarily using the Vbeam Perfecta or Prima for those. Samantha, can you just explain how the questioning system works before we start?
Yes, you can write a question inside of the Q&A chat, and we will make sure that it's responded by the end of this webinar session. So please use the Q&A chat instead of the chat window. There's an option there. If you have technical issues, you can reach out to the chat. Thank you very much.
And if we don't get to answer all of the questions during the allotted hour we have, then we will respond to you by email. So I'll hand over to Jens, who's going to discuss vascular treatments using the Nordlys system. Jens.
Thank you, and thanks for joining. You're in the control of the actual presentation, so please give me next slide, Hamish. And you can start the movie. We're starting here with a movie that shows you what can be done with the Candela IPL with the Nordlys. You will see that there's a slight bluing, that's a good endpoint. And you can also see that it is quite rapid, so you can treat a full face in 15 minutes. To the patient, I would normally say you need 3 to 4 sessions, but probably this patient here we could treat in 2 sessions. Next slide. So there are 2 major things to consider, 2 major factors when we're treating vascular. That is the penetration depth of the laser and the spot size. Next. We have here a little more on penetration depth. I've put in several lasers. We start with the KTP that penetrates to 0.8. Then we have the 585 PDL that treats down to 1.3. The Vbeam that Hamish will talk about goes a bit further. And then we have the Nd:YAG that goes down to 6 millimeter. But there's a sweet spot in between. Next, yeah. That is the IPL with the PR handpiece that we just saw in the video. That will penetrate up to 2.3 millimeter. Next. So if we look at the penetration depth of a small spot size, then I'm not sure what that extra thing is doing on my drawing, but never mind. You will see that the density of the light is highest in the triangle just below the spot size. Once you get outside that, then you will have less density, and therefore you will not be able to heat the target. Whereas if you use a larger spot size, then you will have a penetration depth that goes deeper, and you will also have a percentage much higher efficacy of the light than you would with a small spot size. Next. If we look at the lady here, she has some vascular disturbance post-radiotherapy. It has then been treated twice with a 585 PDL. It's clinically a very good result, but there is still something left, so the patient is not quite happy. Next. One additional treatment with the Nordlys, with the PR handpiece, will give us the completion of the treatment. Next. When we started in 2015 with the Nordlys, where we came out with the short pulse, I started working with Ukache, who's a dermatologist in France. He has been working with vascular lasers and IPLs for many, many years. He made a study with the Nordlys and found that he had shorter treatment time, fewer treatments needed, equal or better result than his other lasers and IPLs, better control of the proper threshold, lower running cost, and more treatment possibilities. Next. But the important thing here was that he only used between 5.4 and 6.4 joules to treat diffused redness. So no contact cooling was needed. Next. Here we're seeing a patient before, and then we're seeing the patient just after the treatment. And there is one particular place where he raised the energy to get purpura. Next. The idea was to see if purpura could cut down on the number of sessions. There's no actual clinical evidence that it works for all, but for this lady here, it did. There was a slightly better clearance in the place where he created purpura. Next. Also, we worked with Paweł Surawik from Poland, and he used the Visha camera to take before and after pictures. And in his study, he did between 1 and 3 treatments for his patients. And you can clearly see on the after picture that the results are quite convincing. Next. So the secret behind it is the dual mode filtering. It removes the longer wavelengths, so there's no heating of water in the skin. All the energy is applied in the effective range. That gives us a more desirable result with lower fluence. Next. Now, IPL systems should have clinical intelligence. Since it's a computer, then we can set up a program that just by entering the patient parameters, skin type according to Fitzpatrick, degree of suntan and target size, next, will allow the system to calculate the pulse and the energy that we need. This will, next, give us a shorter learning curve. Now, you can have other systems that say, oh, but we've got suggested settings. But in the clinical intelligence, these settings have been developed over the past 22 years with feedback from many doctors around the world on all different skin types. So the system actually has a collective memory of all these doctors' treatments. And that is what gives you a safe and effective starting point when you do the treatments. Next. So what can we use it for? In vascular lesions, we can use it for telangiectasias, as we saw in the video, diffused redness, poikiloderma sevat, rosacea, vascular disturbance post-radiotherapy, we saw the photo, and scars and port wine stain. When we're saying scars, then we are talking about the red scars, where the target is hemoglobin. Next. Here we have one of my cases. He was very unhappy about his red cheeks. These have been cleared up in 3 treatments. Next. Moving on to the short pulse, we have here a case from Professor Drosner, where he, with a single treatment with 1.5 millisecond and only 6.2 joule, cleared this patient. The picture, after picture, is 1 month after the treatment. Next. Here's another case of mine. She was very unhappy about being pink. So I treated her upper arms, her chest, neck, and face in 3 sessions. Next. It's also good for port wine stains. We will hear more about port wine stains from Hamish in his presentation. But here I've treated this man in 3 sessions. Next. So the platform has, when we're talking vascular, an additional handpiece for indications not suited for IPL. That's the NDAG, and it's used for leg vessels, resistant port wine stain, onychomycosis, and warts. Next. Here we see leg vessels, and that has been treated, and it's before and 21 weeks after 1 session. Next. This here is an interesting case because the complaint would normally be the red net of small vessels, but here you actually need to go in and treat the reticular vein that is feeding this net in order to be successful. So that's why there are 2 treatments, and the after picture is 10 weeks after the 2nd treatment. Next. Also for larger vessels here, they would definitely not be treatable with an IPL, and we do not recommend to use IPL for any size of vessels on the legs due to the increased risk of side effects using the IPL on the legs. But here I treated this lady in a single treatment, and the result, as you can see, is 5 months after a single treatment. Next. It's important when we treat with an Nd:YAG that we remember that an Nd:YAG, when treating vessels, create a pear-shaped heat zone under the skin. And it is very important to keep the distance between shots. Next. Now, the last shot, it was very tempting. There is a little bit of vessel left. So if you place the shot there, you will see that the heat zones overlap. And that will, if you are lucky, give you only PIH, but you could also have burns. Next. So remember that the minimum distance between 2 shots with an Nd:YAG should be spot size times 2. Next. So is the YAG only suitable for leg veins? No, of course it's not. But always remember the distance between shots, spot size times 2. And when you work on the nose, do not go higher than a 1.5 millimeter spot size. If you do, you increase the risk of creating scars due to the bulk heating. Moving on to venous leg, we have here a lady that has had a single session before and 8 weeks after. The settings are below. Next. For periorbital veins, an IPL system is definitely not your tool of choice. You need an Nd:YAG. And here on this vessel, it's before and 5 months after a single session. Here we can use a 3 millimeter spot size. The 1.5 would not be enough, but since this is not on the nose, it is also feasible to actually treat with a 3 millimeter. Then we have a vessel on the nose. Here you do use the 1.5 millimeter, and I treated this man with 3 shots separated over the vessel, and that's 3 weeks later. I saw him in the street a year later, and the vessel was still not back. Next. From Dr. Lee in Korea, we received this photo here because she was adamant that Nd:YAG could not be used on the nose of a Korean due to the risk of scars. But since we had already tested it for exactly Korean skin, we could with confidence say that it would not be an issue as long as she used the 1.5 millimeter. And clearly here, she could see for herself that it was correct. Next. A deep venous leg, also a job for the Nd:YAG. This is 10 weeks after 1 treatment. Next. Now, when we're looking at something like this, it's diffused redness. So the obvious first thought would be, let's use the IPL. But we need to use our thumb to press or a dermoscope to see if there is a feeder. You can see the result is after 4 weeks after 1 treatment. But using the dermoscope on the next picture, you can find the feeder, and then you kill the feeder and the rest of the network will disappear. The Nd:YAG has a attachment with a sapphire window so that you can apply the correct pressure to empty the surroundings and just shoot the feeding vessel. Next. To understand the thermal relaxation time and the correlation between target size and the pulse time is essential when we're using the system or any laser for that matter. Next question, or next slide, sorry. I've made this small cartoon here where you can see the body size, the body temperature 37 degrees, destruction temperature at 70. You have a small vessel, a large vessel, and a shorter and a longer pulse. When we do the large target with the long pulse, we will gradually heat up to the 70 degrees. Next. If we treat a small vessel in the same area, the temperature will not arrive at 70 because it is losing the heat much faster than we can supply it. So next, in order to treat the small vessel, we need a short pulse and then we will arrive. Next. A short pulse on a large target will simply not be adding enough energy to heat up the target. Next. We have here a young lady with a port wine stain in the neck. And you will see now that I start treating that the lesion is changing color from pink to what in the video looks like a slightly brown, but it's actually purple. I did 3 shots and then I asked her if she was okay, and she said, yeah, keep at it. And it's important to remember here that there's no need for any cooling, and I only used 6.2 joules, 1.5 milliseconds. And there is no need for any anesthesia. So the Nordlys is one system that can treat vascular lesions, pigmented lesions, photorejuvenation, acne, PDT, though not FDA approved. It can do hair removal in skin type 1 to 6. It is in effect the only IPL that's approved to treat skin type 6. Next. Next. So we got documented results, fewer treatments required. It's fast and easy. Next. 22 years in the market. Next. And the big spot size will, through the scattering, offer a much better absorption than target. Next. If we add the Nd:YAG, then we can do leg vessels, resistant port wine stain, onychomycosis, and warts. Next. And we can also add a Frax 1550 for non-ablative skin resurfacing, acne scars, striae, and surgical scars. Next. So this slide here, I'd like you to really remember. The Nordlys narrowband with an IPL handpiece that can do from 530 to 750 nanometers with a pulse time of 1.5 milliseconds has a penetration depth of up to 2.3 millimeter and sufficient energy to create a perfect response. Next. And the take-home message, when we talk narrowband IPL or SWT as we call it, is that there is no water absorption, no wavelengths above 950. It's lower energy applied to the skin, and therefore there's no need for skin cooling. Remember that systems that use active skin cooling, contact cooling, they will cause vessel constriction. The Nordlys will not. We've got the HRD 645 applicator, which is the only IPL applicator approved to treat skin type 6 for hair removal. It's the only IPL with a power pulse, short pulse. Typically, we work between 1.5 and 2 milliseconds, but we do have pulse times down to 500 microseconds. That was a bit fast. So we got deeper penetration than the KGP, better control of the per threshold than the 585 PDL, low running cost, and combination possibilities with the Vbeam to get improved result is definitely something to consider. Next. So for the Nd:YAG, it's the only Nd:YAG with automatic adjustment of the spot size. So you choose the target size and the Nd:YAG will automatically adjust the spot size for what you need. So it's based on the clinical intelligence. It's also got soft cool, which is focused airstream. It's integrated. You don't need an additional cooling system that will cool exactly where you need it. And it is not as uncomfortable as some of the systems with contact cooling. Next. Thank you very much. Are there any questions? Then please type them into the Q&A.
Thank you very much, Jens. Do we have any questions? I don't know if anybody can see.
Thank you, Hamish. Thank you, Jens. No, there aren't any questions. Please proceed with another presentation.
Okay. So following on from you, what we're now going to do is we're going to look at how we treat hemangiomas and port wine stains. So Mulliken's classification system is looking at separating any congenital vascular lesion into either a vascular tumor. So these typically have a rapid growth either at birth or shortly afterwards. Normally, if it's not at birth, it's within a couple of weeks after birth. They eventually regress. It can take 9 months, sometimes longer than that, and this generally is the group that we're looking at, hemangiomas. The second area would be vascular malformations. So this is where we have errors in the embryonic development. These can grow with the child, but they're very slow progression. And you can also have capillary vascular malformations, which generally we call Port-Weinsteins. And also we can have venous, lymphatic, and arterial malformations. So two very distinct groups, but they can look very similar without taking the history. So it's very important that you always take history before you decide how you're going to treat whichever condition you're looking at. So diagnosis. Benign vascular malformations of the newborn can be difficult, as I said, to classify because there is a great variety and overlap in both the clinical and the histopathological appearance of, particularly of hemangiomas and also Port-Weinsteins. So how do you classify them? Looking at the lesion and taking the patient's history, does that lesion have proliferative or a regressive phase? So hemangiomas do have a more so a regressive phase, and these are called cellulary dynamic, whereas a Port-Weinstein generally don't have this proliferative or regressive phase and are called adynamic because of that. So let's look at hemangiomas. It's one of the most common tumors in infancy. Between 2 and 3% of neonates and 10% of infants. Remember I said that particularly with hemangiomas, they don't always appear at birth. Sometimes it will take a couple of weeks and even a month or 2 months before this hemangioma may appear. It also is common in 20% of premature infants. And for some reason, and nobody really knows the etiology behind this, but it's 3 times more common in females. Treatment. In many cases, there isn't any treatment that's actually required. So generally, if a young baby presents in either a dermatology or vascular department, the first thing that you will do is take a history, and secondly, you will probably just want to wait. However, there's a couple of areas where you will be looking at wanting to treat this immediately. If there's any threatened function, so whether this be vision or if it's affecting the mouth, so feeding becomes very difficult. If it's very rapidly growing, the issue with rapidly growing hemangiomas is they're more likely to ulcerate. And also, if there's any risk of any kind of deformation, so particularly on the face. And the final reason will be if this hemangioma has actually ulcerated. So as I mentioned before, if the history is showing that this hemangioma is rapidly growing, it then means there is a bigger risk that it will ulcerate, so you would want to treat it. But in some cases, if the patient's not presented early enough, then this ulceration would already have taken place, and then it's a case of needing to treat that ulceration. So the treatment options, obviously observation first, look at the lesion, see how it's progressing, whether it is increasing, whether there is a risk of ulceration, etc. You can use steroids, and these can either be topical or systemic. Beta blockers are another treatment option. If the lesion has ulcerated, then you use pulse dye. And if it's rapidly growing, so the risk is that there's going to be an ulcer, then again, you would use pulse dye. Or the final option would be some kind of surgery to basically to affect the vessels within this hemangioma. And here we have a nice set of before and afters with the progression from pre-treatment to 2 or 3 treatments into the final treatment. So you can see the majority of this tumor has been removed. So considerations when you're treating with a pulse dye, determine if the treatment's needed, then think about the appropriate therapy. Generally with the Vbeam, previously we have used either a 10mm or a 7mm spot size. Short pulse durations of between 0.45 and 1.5 milliseconds. But if the vessels are larger, as Jens was explaining, then we need to increase up to maybe a 6 millisecond pulse. So we were able to get to that 70 degrees threshold that he was explaining about to get the coagulation of that vessel. The fluencies, we start generally conservatively around about 5 joules per centimeter squared. And as we progress through the treatment, we'll look at increasing it up to generally a maximum of 7.5 centimeters. We use cooling, so we use our dynamic cooling, the cryogen spray. But we, particularly if it's a very rapidly growing lesion, then we will use low fluencies, because the danger here is we can do too much collateral damage to that tissue, and then we can cause an ulcer. An earlier treatment can be beneficial, particularly if these are much more superficial lesions. So if you get to the stage where the hemangioma is reducing, but you still have some residual redness, it's possible to use a fractional system for that kind of fatty residue that can be left, the very uneven looking surface. So looking at a couple of studies, here was a study retrospectively of 90 patients, and there was 105 superficial or deep hemangiomas, and the average age was 3 months. We used a Vbeam, so the 595 nanometer wavelength, with dynamic cooling, cryogen spray, and anywhere between 2 and 8 treatments. Spot size, as I mentioned before, between 7 and 10 millimeters, same fluencies and same pulse durations, and 85% of the subjects exhibited near or complete clearance of the lesion color. And additionally, 64% of the patients showed a near or complete resolution of the thickness of the lesion. And the average number of sessions was 6.7. The benefits of early treatment, another study, 5 infants here, ranging between 1 and 3.5 months, between 2 and 8 treatments. Parameters, very much the same as before, but you can see the fluencies have gone from 5 up to a maximum of 10 joules per centimeter squared. Again, cooling, really important to use the cooling. And the interval between the treatments was anywhere from 2 to 8 weeks. And this study showed no scarring or atrophy. Ulceration occurred in 1 case and resolved during the treatment cycle. 4% showed hyperpigmentation and 14% had some hypopigmentation. So very effective treatment. And here we can see again the progression from pre-treatment to intra and then post-treatment. It's a very nice clearance of this lesion. And this treatment would have been done. Obviously, you can see we have involvement around the mouth, and it looks like potentially there's a little bit of ulceration going on the top lip, and also the danger of inclusion of the eye socket. So we'd be worried about sight and also feeding for this small child. Hence the reason the treatment was done. As I mentioned before, we can also treat hemangiomas once they've ulcerated. And this was a study of 78 children. and 91% of them responded to the therapy. And it's also thought that by using the Vbeam, you can actually reduce the amount of pain. But ulceration can be a complication, so the approach should be cautious. And again, as I mentioned earlier, you start with lower fluencies and then increase as you go through the treatment. And here we have almost complete resolution of this ulcer. Potentially one more treatment and we'll have cleared up this ulcer. So let's move on and look at port wine stains. So subtle differences between hemangiomas and port wine stains. These are intradermal capillary malformations, and port wine stains are always present at birth and remain persistent through life without regression. Very similar incidence to hemangiomas, 0.3% of newborns can present with port wine stains. They also can occur anywhere on the body, but they're much more commonly found on the face. And also they can follow the distribution of the fifth cranial nerve. So you will see typically a lot of port wine stains around the eye or in the cheek area. Each port wine stain is different in terms of its size, its color, and its texture. And as the child grows, the port wine stain can become darker and also thicker. And particularly more so into adulthood, can develop nodules, which eventually either need to be excised or they can, in some instances, be treated with an Nd:YAG. And it's also, I think, important here to think about, due to these changes, there can be psychological and cosmetic concerns, which is why in many cases it's important that we treat these port wine stains in children. And if we don't treat them, then 60, up to even 70% of the lesions will undergo the changes where they become darker and we get these nodules appearing within the lesion. So in 1981, Roxanson produced a clinical paper where he was looking at using a pulse dye laser to treat specifically port wine stains in children. So this became the beginning of the Vbeam. So we produced our first Vbeam laser. In fact, it wasn't actually called a Vbeam, but we produced it in 1986. And it was literally introduced to treat port wine stains in children. And for medical lasers, it's in the slide here, it says over 300. That figure is probably nearer 400 published clinical papers now. So there are more clinical papers covering pulse dye lasers than any other laser we use in aesthetics or in medicine. So if we look at the treatments, 99% of port wine stains will lighten if they're treated at less than 6 months. 60% will clear. And if they're treated post 6 months, 20% will clear. And also you find the residual vessels will continue to dilate, and this is why the vessel becomes darker. There's a number of different treatment options. Obviously, pulse dye laser with our Vbeam. It is possible to use a KTP or frequency doubled 532 Nd:YAG. The issue with the 532 is it's a very superficial wavelength. So you may remove some of the more superficial lesions, but the deeper vessels, you'll not reach that target with a 532. You can use a 755 alexandrite. Generally, these are used much more for the resistant lesions where you've explored all the other treatment options and you get to an impasse in the resolution of this port wine stain, and then you can think about using a 755. The Nd:YAG Generally, we would consider using this mainly for the nodules that can appear as this lesion progresses. As Jens was mentioning, we can use the Nordlys system either with the SWT/IPL handpieces and also the ND-YAG. And the final option, which obviously is a much more aggressive kind of treatment, would be to use an ablative fractional laser. So if we look at the Vbeam treatment, pulse durations very similar to what the ones we were discussing with the hemangiomas. So anywhere from 0.45 up to 6 milliseconds. But you generally find when you read through the literature that the clearance is quicker with less sessions if you're using the purpuric settings, which is where you're at 0.45 or maybe 1.5 milliseconds. Historically, we've always used a 7 millimeter or a 10 millimeter spot size, but I'll go on to discuss towards the end of the presentation where we've kind of moved the goalpost now with our Vbeam Prima, because we're able to use 12 and 15 millimeter spot sizes effectively. The reason that historically, before the Prima was launched, that you would find most clinicians using a 7 or a 10 was because you need a fluence of anywhere from 6 joules per centimeter squared up to 13 joules per centimeter squared. And with the Perfecta or Vbeam 2, it was difficult to achieve those kind of fluences with a 12 millimeter spot size. We always use our cryogen spray, our dynamic cooling. In some cases, consider multiple passes. But if you are going to do multiple passes, then you need to lengthen the pulse width. And also watch the skin very carefully. The desired endpoint is purpura, as Jens showed in his video, but we don't want to be too aggressive so we end up with graying or whitening of the tissue where we're actually damaging too much of that surrounding tissue. This is a study by Bernstein and Geronimus, where we looked at 197 infants. So this was a retrospective review of this cohort of patients using Vbeam Perfecta. And you can see here the spot size was anywhere from 10 to 12 millimeters, and the fluence 6.5 joules up to 9 joules. And here, purpuric settings, so 0.45 up to 1.5 milliseconds. And for some of these patients, there was a topical or a general anesthetic, topical or general anesthetic was not administered with this 197 infants. And the grading was done independently by 4 physicians. And you can see using the 5-point scale that we were getting excellent results. So we had 67% of the patients showed more than 75% improvement. And here we have one of the patients. So this was 12 treatments and the average fluence was 8.9 joules. And the age of this little one was 13 months. But very nice improvement in this lesion. Here we have a treatment of an adult, and you can see that this port wine stain is starting to thicken, which is very commonly what you see as the patient gets older. But again, very nice clearance. So don't have the treatment settings for this one, unfortunately. Can also treat port wine stains in darker skin types. Generally, when we're discussing the Vbeam clinically, we don't normally want to move much beyond skin type 4. However, when we're treating port wine stains, it is possible to treat much darker skin. We tend to use lower fluences and potentially longer pulse durations. So we were using a 1.5 millisecond pulse here rather than the 0.45. We still want to see purpura as our endpoint, but we don't want to see too much purpura. But I think, as you'll agree here, we have a very nice result. And it's also interesting to point out that you can see how the skin color has darkened during the 3 months since birth, child. And there's no PIH, there's no hyperpigmentation, very nice natural skin color following the treatment. I mentioned earlier that we can also look at treating port wine stains with an alexandrite. This was another Rox Anderson paper. So here it was a resistant port wine stain that had been treated previously with a pulse dye laser and got to the stage of not seeing an improvement from one treatment to the next. So they moved on to using the alexandrite 755 nanometer. And again, a nice improvement in the treatment. This is actually one of Jill Weibel's treatments rather than one of Rox Anderson's, but it was based on the clinical paper that he produced. So treatment. Normally we treat every 4 weeks, particularly if it's facial in lighter skin types. So for instance, with the skin type 6 child that we saw, or infant that we saw earlier, it would have probably been 6 or 8 week intervals between treatments. And we also use longer intervals if we're treating the abdomen or the limbs, to again between 6 and 8 weeks. For darker skin, as I mentioned just now, longer intervals where there's a risk of hyperpigmentation, and we need multiple treatments. It is possible in some cases that we only need 3 treatments, but it can be as many as 15 depending on the severity of the lesion. So let's have a look at the way that we can change the whole concept of how we're treating hemangiomas and also port wine stains with the Vbeam Prima. One thing we have is we've added a second wavelength, so we now have our 595, which we've always had with our Vbeam, but we've also added a 1064 ND-YAG. So this gives us the option, particularly when we're talking about port wine stains, if we have nodular elements within that port wine stain, we can treat those with the ND-YAG. But obviously on a wider treatment option, having an ND-YAG means we can treat leg veins and thicker, deeper vessels than we can with our pulse dye, with our Vbeam. And you can see, excuse me, the treatment options with the Prima. We can treat right from hemangiomas and angiomas that we were talking about just now, to facial telangiectasias, our port wine stains, rosacea, poikiloderma, even pigmented lesions, and then we can move into the deeper, bluer vessels with our ND-YAG, including venous lakes that Jens was showing earlier on. And also, we can use the system to improve fine lines and wrinkles, improve collagen, reduce pore size, and generally give a photo rejuvenation effect for the patient. We increased the spot size from a maximum spot size on the Perfecta was 12 millimeters, and we've now moved up to a 15 millimeter spot size. So just by increasing the spot size wouldn't necessarily have given us more treatment options or more effective treatments. So we actually doubled the energy that we can deliver with the Prima over the Perfect. So it means not only are we able to use bigger spot sizes, but we have a strong enough fluence in that large spot size to be able to get effective results and see the clinical endpoint that we're looking for. So previously with Perfecta, the 12 millimeter spot size would have gone to a maximum of about 6.5, possibly 7 joules per centimeter squared. We can now get to 10.6 on the 12 millimeter, and on the 15 millimeter, we're still up at 6.8 joules. As you noted from a lot of the settings that we've been discussing in the presentation, 5.5 to 6.5 is a fairly typical fluence that somebody would be using for both hemangiomas and also port wine stains. So we can treat with a bigger spot size, see the clinical endpoint that we're looking for. But if you look at typically the 10 millimeter would have been the spot size of choice for many clinicians when they were treating these lesions. We're now using a 15, which means it's 125% larger treatment area. And this is particularly important when you're looking at treating neonates or infants. Particularly, I think you find in general within Europe, if we're treating neonates or infants, they will have a general anesthetic. And clearly we want the child to have as short a time under anesthetic as possible. So if we're able to use the 15 millimeter spot, we're treating that area much more quickly than if we were using a 10 millimeter. So one, the treatment is quicker. Secondly, the anaesthetist is much happier because he's not having to administer so much anesthetic to such a small child. And to show that it's more effective, here we have a couple of case studies from Firaz Al-Niami. You can see this is a patient he had in his clinic who'd had a number of treatments with a Vbeam and it got to the stage that there was no improvement. This was with a Perfecta. He switched over to the Vbeam Prima. We're using a larger spot size, and you can see in 2 sessions a large amount of extra clearance in this lesion. And our second patient here, similar kind of history, got to the stage that the port wine stain was not improving using smaller spot sizes, so moved up to the 15 millimeter for 1 session, and then the 12 millimeter for the 2nd session, and a great deal of increased clearance in this. And the settings you can see along the bottom, typically 6.5 joules, maximum 7.5 joules, and 0.45 millisecond pulses. So if we look at finally the typical settings we're going to use for port wine stains, particularly with the Prima because we have the bigger spot. For an adult, 15 millimeter, 1.5 milliseconds, 6.5 joules per centimeter squared of fluence. And if you're finding that 6.5 joules doesn't give you the purpura you're looking for, the beauty with the Prima is we can change the spot size in 1 millimeter increments. So rather than having to go from a 15 millimeter to a 12 millimeter, we can literally drop by 1 millimeter diameter and increase the fluence to 7, and that 0.5 increase is in most cases enough to see the purpuric response that you're looking for. When we're treating neonates or pediatrics, we're looking at the big spot size again, the 15 millimeter, because it means we can treat the area much more quickly, so there's less anesthesia required, but we're starting with slightly lower fluences, starting generally at 5 or 5.5 joules per centimeter squared. And as you progress through the treatment regime, you may want to increase for the neonates to maybe 6 joules, but generally you don't need to go much beyond 6 joules. So that's, in a nutshell, hemangiomas and port wine stains. And I guess we open it up to any questions. Let me see if I can find any.
Do you see the question?
I am, yeah.
We have a patient diagnosed with rosacea. Multiple treatments with ellipse PR up to 1.8 millimeters, 8.5 joules were given. Patient responded with purpura to the treatment, but eventually without any results. Is seen on the tip of the nose and forehead. How would you suggest to proceed? Other settings or Vbeam, Alex or NDAC?
Would you increase those settings, Jens?
Why did they stop at 1.8 milliseconds? I would have gone further up to 2 milliseconds, and then you'll get more energy, and then try there. The other thing that I would like you to try is to see how high is the flow. Push with the thumb. It will always give you a good indication to see how fast the flow comes back. The faster the flow in the rosacea patient, the higher you will need to go. Did that answer your question?
We can also then consider treating the diffuse redness. We could use the NDAG on the Gentle series, Gentle Pro series, to treat that diffuse redness. I don't see any other questions.
Nope.
No questions further. Hamish?
Okay, well, in that case, thank you very much, everybody, for dialing in. I hope you found it useful. And if you do have any questions, generally what happens is you dial out and then you suddenly think of a question. And if you do that, you can either contact myself or Jens or Samantha, who will pass the question on to Jens and myself. So thank you very much. And thank you, Jens.
Thank you.
Thank you all. This is the end of the webinar.